So I'd just like to acknowledge we have an increasing number of corporate partners here at TSA, and I'd just like to acknowledge those partners and the support that they are giving to our organisation, particularly AFT Pharmaceuticals, who've recently come on as a corporate partner, which is just, you know, fabulous support for the organisation. I also want to give a quick plug because it is TSC Global Awareness Day next Thursday, the 15th of May. And as most of you know, we have our Light the Way campaign, which is raising funds this year to try and increase the hours that our TSA nurse, Katrina, who's also on the call tonight, is available to support everyone in the TSC community. So if you can try and get involved in that, we would really, really appreciate it. Number of ways you can get involved: hosting a celebration, sharing information about TSA and about your TSC story with your network, donating if you can, and just sharing generally to make sure that we get really good awareness of the campaign and also of TSC, because it's really important that we try and raise that awareness throughout the community. So if you want to get involved in Light the Way, like I say, there's many ways you can do so. This year we're talking about hosting events at home. There's lots of things going up on our social media at the moment. If you want any more information, please visit this website, lighttheway.org.au. And if you need any more information that you can't get there, then please just get in touch with me, because we would love to hear from you and love to get you involved in that. Now I'm going to stop sharing my screen and I'm going to stop talking, and I'm going to hand over now to Dr. Clara Chung and Dr. Nis Chan, who I introduced at the start of this. And I think, Clara, you're going to start. If you can take yourself off mute and share your screen, and if everyone can make sure that they give a very appreciative welcome to our lovely doctors who are sharing their time and expertise this evening. Thank you.
Well, thank you, Jackie, for inviting us to talk about this topic. Hopefully, we will be able to do it justice and to hopefully help everyone understand this topic a little bit more. Denise and I will go through the presentation, and then we're of course more than happy to take your questions afterwards. Hopefully we can answer them. If we can hold the questions till the end, mainly because I can't see any of the questions during anyway, that will be great. Hopefully everyone can see our slides now, and if so, I might get us started. I've actually closed everybody, so I can't.
Can we get confirmation that it's okay?
We can see it loud and clear.
Perfect.
Great. Thanks,
All right. Oh well. So as Jackie said, I'm just going to make a start. So I always like to start with this, just so that we're all on the same page. So apologies to those of you who have heard this before, but I always like to start with just the general concept of sort of genetics and how that controls the body, and more specifically for TS. We have genes that tell our body to grow and genes that tell our body to stop growing, and it's like a bit of a balance between the two groups of genes that gets us, the right size, make sure weird, like big lumps and things like that don't grow. And of course, it's an imbalance or a problem with this balance that leads to things like atherosclerosis. And we'll go into that in a little bit more detail. This is the mTOR pathway, which we can't avoid talking about when we're talking about mTOR inhibitors. I completely acknowledge, and even this is scary to me, I don't understand most of what is going on here, but this is just a general sort of picture, and we will simplify this or point out the bits that are important to all of us. But the reason why I put this picture up at the beginning is, of course, the reason why we talk about the mTOR pathway is because the TSC1 and TSC2 genes are on the mTOR pathway. And so before we go any further, because we love talking about mTOR as the abbreviation and the acronym, because everything else is just a mouthful, just like TSC, just like TSA, just like everybody. So mTOR confusingly stands for either mechanistic target of rapamycin or mammalian target of rapamycin. And realistically, the two are used interchangeably. The word mammalian was used because, of course, we know it has effects in mammals, and mechanistic because we think potentially calling it mammalian target of rapamycin might be a little bit too narrow, and it's the mechanism of it targeting rapamycin, which is why that is. But realistically, mTOR, luckily both start with an M, and that we just call it mTOR. But that's why you can see those interchangeably when you read about it sometimes. Going back, the important things about mTOR is that it's part of two particular complexes in this very complicated diagram. So the first one is mTOR1, and this is mainly involved in regulation of cell growth. And the other one is mTOR2 up here, which is more to do with sort of how cells survive and grow and proliferate. So proliferate as in, multiply in number, things like that. And so these are the sort of things that we'll remember when we sort of talk about how this affects TS as a condition. So I always like to sort of make things a little bit more fun. So today we're going to talk about the mTOR journey, like it's a little bit of a road journey. So bear with me if you think this is a little bit silly, but our journey is going to start off with rapamycin being discovered back in 1964. So it all started on Easter Island. So a group of Canadian researchers and scientists went to Easter Island, and they found it's a rapamycin, which is now called rapamycin, as something that was being introduced by bacteria. And then they found that it has quite helpful sort of antifungal and anti-cancer properties. And they named it rapamycin based on the indigenous name for Easter Island, which is Rapa Nui. And so that's sort of where this whole journey starts. And of course, mTOR inhibitors, we probably have heard a lot about as a group of people involved in TSC. The two that are most, there are more than two, but the two that we care most about with relation to TS is, of course, sirolimus, otherwise known as rapamycin. So that's the first one that we've ever discovered, and everolimus, which is also can also be known as Afinitor. So there's a couple of pictures here for those of you who've probably seen the boxes or the bottles before. And mTOR inhibitors mainly target mTORC1. If you remember when we were talking about mTORC1 and mTORC2, so the mTOR complex 1 and mTOR complex 2. And this might or might not work, but this is how I've decided to picture it. So if you pretend that this octopus is rapamycin, and you pretend that the octopus only has two arms, which is this one and this one here, because so the rapamycin has two sort of things that it can attach to things. So and so what it does is it first attaches to this protein called FKBP12, and once it attaches to that, then it opens up this one and it allows it to attach to mTORC1, and so that's how it sort of inhibits mTORC1 in a way, in a very, very brief way. And so going back to our journey, we've discovered rapamycin now, and then in the 70s, they found out that it could be used in immunosuppression. That was sort of the first use of rapamycin. So you may have heard that so it started being used for organ transplants, often kidney transplants. And then, so that was in the 1990, and then they actually they started using the drug before they worked out sort of why it worked and how it worked. So they discovered the actual mTOR pathway in 94. They discovered those two complexes that we talked about in the early 2000s. And then they, in sort of those in 2017 to 2012, they started using it for anti-cancer things. So in renal cell carcinoma, it works for a few, it doesn't work for many. And so, that's sort of how it all started. Of course, as you can appreciate, that none of this at the moment has anything to do with TS. So how does it actually relate to TS? Like why are we talking about mTOR inhibitors? Because the drug wasn't first discovered to be used in TS, but what they found. So back here, we remember how we found the mTOR pathway in the mTOR1 and 2 complexes. So back in 1993, they discovered TSC2. They did discover TSC2 before TSC1. And 97, they discovered TSC1. And so then they worked out that these two genes like to live in a little complex together. So they like to bind together and be in a little group. And they worked out that actually together as a complex, they are on this mTOR pathway. So they inhibit mTOR. So it's one of those back to sort of growth genes and stopping growth genes. It's one of the stopping growth genes, right? Or both are. And so they are a bit like a brake on the mTOR pathway. So unfortunately, when that brake doesn't work properly because one of the two genes are not working properly, then we get an overactive mTOR. And what that overactive mTOR leads to, so thinking back to what sort of mTOR1 and mTOR2 does, it leads to abnormal cell growth and cells proliferating too much. And so that's when we get all the funny growths that we know, or we all know about, right? So the SIGAs in the brain, or the cortical tubers in the brain, and the SENS in the brain, or the rhabdomyomas in the heart, or the AMLs in the kidneys, and the angiofibromas that you get on the face, and all, those are just the most common ones. We all know there are a few others. What it also can lead to is a typical connectivity. We don't quite know how that works, but it just doesn't, the neurology part of it doesn't quite work so well either. And that's what leads to the seizures and the developmental delay and the autism and the behavioral things that we all know are also a big part of TS. And so another way to conceptualize this, I found these slides from Darcy Kruger, the neurologist in Cincinnati Children's. I decided I'll borrow them. So the TSC1 and TSC2 gene, or the complex, limits the mTOR activity. Okay, and so when that doesn't work, mTOR can sort of run amok and go out of control, and then going sort of the drugs, so the sirolimus and everolimus as mTOR inhibitors, puts that inhibition back on. So adds those limits again, and so the mTOR doesn't, go amok anymore. And so now that we found out that, actually, the TS genes, are on this pathway, we started using it to see if it works. And so, so the first one we did was in 2012, and was the big study called EXIST that we used in SIGAs. And this is when I'm going to pass the time over to Dr. Chan to talk a bit about those.
Hi guys, thanks for tuning in. So I get the fun part of presenting EXIST 1, 2, and 3, these seminal studies that really talk about and are the evidence base for why we can use everolimus. So they were all using everolimus and not sirolimus. So EXIST 1 talks about trying everolimus versus placebo in a group of patients. And that is patients with tuberous sclerosis who have a SIGA. EXIST 2 is when they used it for AMLs, and EXIST 3 is when they used it for refractory epilepsy associated with tuberous sclerosis. So this one, EXIST 1, talking about the SIGA. And I want you to focus your attention on the MRI sequences on the right. We've got two patients there. So the first patient is in the top row, so we'll ignore the yellow arrows for now. And you can see that for patient 1, they started off, so this is a baseline scan without everolimus. They started off with a big SIGA on that right side in the ventricle of the brain. And then, I don't know if you can see my cursor there, but I'm just going to point that out. And then after, I think probably 12 weeks, you can see that here, it's gotten smaller in size, and it looks like it's probably shrunk. It's about half the size, but in cubic centimeters, it's probably, more than that. So when we look at the second patient down here, there's a couple of different things you can see. So firstly, there's a little hole here, and it looks a little bit mucky. That's because this patient previously had some SIGA surgery, and then it was unsuccessful, is what the paper says. So I don't know if it was unsuccessful because they couldn't quite get to it. It was unsuccessful because it was too adhered, or because it grew back. I'm not too sure of that. But you can see that I've just circled it in yellow there. So if I click again, you can just see that tiny spot there. And there's this swelling around it as well in white. So we call that kind of white matter edema. And so in 12 weeks, what happened from the baseline scan on this person with everolimus, you can see the tubers around the side as well, is that that lump has gotten smaller, again, halved in size, although that's not for everybody halved, but it definitely has gotten smaller. And that white matter edema, where it's probably pushing on stuff, is less angry looking. You can see that it's still sort of there, but definitely reduced in the swelling. So that's two of the patients that were this is lifted directly from this particular paper. In general, it's not just talking about these two patients, but how many patients they have. I think they had 117, and whatever 78 plus 39 is, which I'm sure is not 70. Oh, it is 70.
No, it's 117.
117.
You're right.
Right, there you go. I'm not very good at maths. So if you look at this, down the bottom, on the left, we've got everolimus, and on the right, we've got placebo. So it was a 2-to-1 randomization, which they usually do 1-to-1, but I think the FDA was happy to do 2-to-1 because they were pretty sure that it was probably going to work, and there had been a few case studies prior to this showing that it did work. So it was better to tell people you're more likely to get everolimus than not. 35% of the people in the SIGA group got a SIGA response. The arrow down means the SIGA shrunk. And 0% of the people on placebo had any response. So the SIGA did not shrink by itself. And actually, SIGA response in this is defined by a more than 50% reduction in SIGA. So if you had a 40% reduction or a bit just a third, got less by a third, then that would be not technically a SIGA response. You can see here on the left, I've written that same thing. But actually, if you don't have such a stringent criteria for SIGA response, and of course that's important for scientific studies, but if you don't look at that criteria and you do it a bit more lax, by week 24, so 6 months, 78% of people in the everolimus group had a reduction of 30% or more compared to 15% in the placebo group. Okay, so some of the placebo group shrunk a little bit, not much. None of the SIGAs in the everolimus group progressed. They didn't get bigger, compared to 14% of those in the placebo group. And on top of that, because this is their first study, they also looked at these people who also had AML. So if they had AMLs, 53% of the ones in the everolimus group had a response in the AML getting smaller, whereas in the placebo group, their AMLs did not get smaller. And if they had some skin lesions, then 42% had some regression in their skin lesions, but they did know that it was an incomplete response in the paper. And 11% in the placebo also got better on its own. But you can see that there is about a 31% difference in those two groups, and a big response in the AMLs did not go by themselves. This is another way of looking at the data. And really, it talks about the risk that your SIGA is going to stay the same. So the probability of your SIGA staying the same at 6 months, if you're on the everolimus group, is that it will probably stay stable. It would not progress. That's what it looks at, not non-progression. Whereas there is about an 86% chance that, or 82% chance that the SIGA will be non-progressing. So, 18% that it will progress by 6 months if you're in the placebo group. So that's another way of slicing the data. Okay. So now we're going to move on to the next year. They were also running studies in the AML group. Again, we've got the same scale here. You can see that there's more evidence weighing down on the everolimus side. Again, a 2-to-1 randomization, 79 people in the everolimus group compared with almost 40 in the placebo group. Again, we see a big difference between the rates of AML decreasing in volume, so 42% in the treated group of everolimus versus 0% from the patients treated with placebo. In the everolimus group, 3 patients with AMLs did progress, so it wasn't 0 progression, there were 3. However, there were much more in the placebo group that did have disease progression as well. So everolimus does work, but sometimes it doesn't. The EXIST2 paper didn't have a lovely little picture for me to show you, but this is a picture from another study, just a case study showing everolimus treating this AML here. So on top of that, you've got a different organ, probably the liver. You can see this, I've put a little bracket around it, and that measures 4.5 centimeters. And after 3 months of everolimus treatment, you can see it's shrunk to about half here. You can see the little blob still there, 1.9 centimeters. So 4.5 to about 2 centimeters over 3 months of treatment. And this is, again, similar to the SIGA graph you saw. So it's talking again about the probability of angiolipomas not progressing or being progression-free. And over time, you can see in red, the everolimus, it does progress, but there's a difference between a red line and the blue line in placebo. So you're more likely to stay progression-free, I think is one way of looking at it. You're likely to not progress. You have the better chance of not having your AML get bigger if you're on everolimus compared to on placebo. And this is over time as well. So you've got 12 months here, 24 months there, and you have a little dip over time. So the next thing was EXIST-3. That study looked at not a solid organ tumor associated with tuberous sclerosis, but with epilepsy. So the data is a little bit more difficult to slice. But I'm going to start by talking about what drug refractory epilepsy is. A lot of people with tuberous sclerosis have seizures and usually presents in the first 2 years of life, and that's about 80 to 90%. After the first 2 anti-seizure medications, which means drug refractory epilepsy, after the first 2 anti-seizure medications, the likelihood of the next medication working is 10% and then 5%. So we're always doing medication trials, as many of the families online have tried, I'm sure. The chances are low. And so we talk about the different other options associated that we have. And instead of using a conventional anti-seizure drug, we're always trying to look for something new. And everolimus and sirolimus kind of give us a promise that it's really the mechanistic target of rapamycin, as Clara says, or really in the realm of what we call precision therapy. So it doesn't work necessarily for other epilepsies, but this one targets specifically the gene change behind TSC. And so just to go to the blue box that I missed, so drug refractory epilepsy defined by the International League Against Epilepsy is the failure of trials of 2 tolerated, appropriately chosen and used anti-seizure drugs, either by itself or in combination, one and the other, so Keppra or lamotrigine, for example, to achieve sustained seizure freedom. Okay. And so this slide is very busy on the left, and it's just demonstrating that there are many different anti-seizure mechanisms, and the drugs we use, for example, the biggest box, which is the top one on the right, starting with phenytoin, carbamazepine, oxcarbazepine, etc. That one is a sodium channel drug. So these are all sodium channel drugs, and we try to do different things to target the medical problem from multiple perspectives. You can see under that box we've got Keppra, and then there's a couple of different drugs that you're probably a bit familiar with. On the right, I've put in a little cartoon of the different boxing moves, so a jab and a hook and a cross. You don't want to do the same thing over and over again. Then you're not going to win. You jab, 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 jab. So you might want to throw in an uppercut by using, an mTOR inhibitor, something a bit different, just to try. So again, mTOR inhibitors for drug refractory epilepsy is really trying to target the root of the problem and not just putting out the fires. When we use an mTOR inhibitor, everolimus specifically, for epilepsy in tuberous sclerosis, we aim for slightly higher trough levels. And there's evidence behind this, and I'll explain why. So in the EXIST-3 study, they aim for people in, we compare placebo, everolimus at a low dose, and everolimus at a high dose, and doing blood levels on that. And just in general, 28 to 40% of people who took everolimus had less seizures, and I'll show you the data in a second. Half of the people who went into the EXIST-3 study were on 3+ anti-seizure drugs. So that's quite tricky to treat epilepsy, and I'm sure they've definitely fulfilled the criteria of drug-resistant epilepsy at that point. And the people on the study usually had 35 to 42 seizures on average a month, 1 or 2 a day, really. And the outcome, we talk about whether they're, it's a positive outcome, and the response, again, high bar, we're looking for a more than 50% seizure reduction, okay? Something meaningful, not just 1 or 2 seizures less. And so again, using this same scale, we've got everolimus on the left, placebo on the right. You can see that, again, it's a 2-to-1 randomization, but with the low and high dose, splitting up the everolimus group, it's really a 1-to-1-to-1 randomization. So in the low dose, and we're aiming for blood levels of 3 to 7, that's 117 people, high dose, 130 people, and placebo, 119 people. I have to say that in the high dose, we write 9 to 15. But realistically, we find, that levels above 12, you start to really get kind of unbearable side effects with mouth ulcers and things. So I generally like to keep it, around 10 or less than 10, sometimes 7, sometimes 5, just depends on what we can. Going to the blue boxes, you can see in the placebo box on the right, the people taking placebo saw a 15.1% responder rate. So they had a 50%, 15% of that group of 119 people had a 50% or more reduction in seizures. And we know that seizures come and go, so that may be one reason. And sometimes you really want a drug to work. This is in comparison to the group on the left. So if you were on the low dose everolimus, you had a 28% of people in the group responded, compared to in the high group, 40%, so almost half, just under half of people responded, had a 50% or more reduction in their seizures. And again, in the orange, just another way of looking at the data. So reduction in like average reduction in seizure frequency, similar sort of thing. If we look at it in table form, this is the responder rate. So you can say, 15.1% of people responded, so 18 out of 119, versus 33 people in that 117 people on the low dose everolimus group, compared to the 51 out of 130 people who then again had a positive response, so 50% or more seizure reduction. And the little P numbers on the top just talk about how statistically significant it is, and they're both very significant. Okay, we're going to now talk about the median reduction in seizure frequency. And again, we see the same thing with the treatment group in low dose and high dose, this incremental effect. So again, I think the incremental effect does show that there is definitely a drug response, but also the higher the drug, the better it is. So, we feel that is working, as long as it's tolerable. Now, I can never talk about everolimus without talking about the side effects, because that's a really big thing. And you don't want to make life more miserable at all. I think one of my sayings is life should be better on a drug and not worse. So these side effects should not be unbearable. And so mouth ulcers is probably the most common, affecting 40 to 60% at any point. Doesn't mean it's continuous, 40 to 60%, because that'd be really terrible. It's usually mild. The things we usually do about it, try to keep on top of oral hygiene, some Kenalog paste, and then if they're older and can swish and then spit, do a little gargle, then we do dexamethasone mouthwash. They do that swish and spit for about a minute a day, about 4 times a day. If it's mild to moderate, then the mTOR inhibitor can be continued. In some cases, obviously, if they stop eating or they're losing weight or anything drastic like that, we might pause it or decrease the dose. One of the things I've learned anecdotally from one of my other neurology colleagues at the John Hunter is that sometimes if you have prolonged contact of the actual drug, whether it's the tablet or the syrup or the dispersion, in the mouth, then it can actually start breaking down and causing like high risk of mouth ulcers. So the ways we try to work around it is either to pop the tablet into an empty gel capsule and then to swallow it, so it gives another layer of protection. So you could try that for a while. And the other thing is sometimes, we talk about giving a little chaser, little shot of juice or something after they swallow it, just to get it out of their mouth. Because the mTOR inhibitor is a mild immunosuppressant, there is a slight increased risk of infections. They're generally mild, although severe cases have been reported, and sometimes we do discontinue it for ongoing infections. Generally, we just, we discontinue for anything other than a mild infection. Yeah, generally we pause it. I think that's what I meant. We pause it for about a week or 2 until they're recovered, if they have fevers or anything like that. Other side effects are menstrual irregularities, and 13 to 37% of women over 13 reported that they had amenorrhea, which is stopping of periods, on Exist 1 and 2 trials. Half of those women, their periods spontaneously came back, and the other ones all came back when they were given a little bit of progesterone. Other things we see with everolimus is that there's increased lipids and cholesterol. Of course, we have to think about this, especially if we're going to give it on an ongoing basis. If it's mild, we treat with some changes in the diet, and if it's severe, we consider dose reduction or addition of medication to try to decrease the lipids, because of course we don't want to increase heart attack risk. The mTOR inhibitors also increase your blood sugar, but usually that's not significant unless you've got diabetes as well. Rarely can cause bone marrow suppression and different problems with blood counts. So we always check that with yearly blood monitoring and more if we need to. It's also a risk of a rash. We don't see that too often, and delayed wound healing. So if they do have surgery, then we often pause their everolimus for 1 to 2 weeks. just to make sure that cell cycle can continue the growth of the body and to heal properly, but it's a little bit surgeon dependent. These are the blood tests we tend to do at Sydney Children's every year, and more frequently if the dose is adjusted. So briefly, I want to talk about what is available on PBS. So on the basis of EXIST 1, 2, and 3 studies, it's all the evidence brought forward by that. The everolimus is now available on the PBS. It has been for quite a while, but that explains why sirolimus is not necessarily available on the PBS, just because it's to do with the drugs that were used in the study. But we do use sirolimus, just not via PBS. And everolimus and everolimus comes in tablets and dispersible forms as well. And you can see there it's to do with solid organ tumors or subependymal giant cell astrocytomas and has to be associated with tuberous sclerosis. As I said, sirolimus not on the PBS. The dermatologists have to prescribe the topical ointment, and only certain pharmacies make it, particularly Woods Pharmacy at the Royal Children's Hospital. And there's a really lovely TSA website on that. As it comes in an oral suspension, it's often used for babies. So if we do have a baby with a giant cardiac rhabdomyoma, we need to try to shrink that because it's causing some outflow obstruction, then we'll often prescribe sirolimus rather than everolimus, just because it's easier to dose and it's safer to dose, less likely to have drug errors, and we can give them very tiny amounts like 0.1 milligrams. I think sirolimus is more lipid soluble, so soluble in fats than everolimus, so it's better to use for making ointments, which is why the topical creams for angiofibromas are often sirolimus, and it also has a longer half-life than everolimus. Hand over to you.
We'll give Denise a little bit of a break in talking. So I'll just tell you a little bit about the rest of what we've done. Of course, EXIST 1, 2, and 3 are probably the 3 seminal papers on using mTOR in TS. But of course, they're not the only things that we can use mTOR for TS. And so the next thing they did was look at its use on angiofibromas, which is what Denise have already alluded to. So the big trial was called the treatment trial, and I know the TSA was highly involved in the Australian little branch of this trial, where they tried to use topical rapamycin. So they used it in 2 different formulations, first a 1% cream, and the other one was a 0.1% cream, and that is also a 1:1:1 ratio. As you can see, the numbers are pretty similar between the 1%, the 0.1%, and the placebo group. And essentially, it's a very similar story to all the others. So they found that those on rapamycin had more of them had improvement. So 81% improved on the 1%, 65.5% improved with the 0.1%. Compared to the 25.5%. As Denise says, people on placebo do improve for various reasons. So we don't expect a 0 there. And what the other notable thing was most of the improvement was noticed within the first month of using it. So this is the pictures. So this is the pictures that were published in that paper for this. So there are 3 people who were on the trial at baseline and at 6 months. So they just did this for 6 months. And as I'm sure you can appreciate, it might be a little bit difficult depending on how big your screen is. There is an improvement. Like they haven't completely gone away, because I think they were all very significantly affected with their angiofibromas, but there is a reduction in the number of them for all of these patients. And looking at these graphs, it's a very similar graph to what you've already seen. So for the 1% rapamycin, the dark blue in all 3 is people who got better. So like these 3 people here. The lighter blue, or the sort of middle blue, is that there was not much difference they could see, and the very light blue is people who got worse. And so on the 1% cream, you can see very large amount of them got better, a few of them sort of stayed the same, got worse. In the 0.1% cream, also a very significant improvement, not quite as much as the 1%. And then when you just have the vehicle only means placebo, so they just got like a gel that doesn't have the drug in it. There's quite a lot of them got worse. It was sort of much more of a mixed bag. And Denise already showed you p-values before, but all these numbers are also statistically significant when they're compared the group. And so that's, and I know there have been more and more trials after this, but this was the very first.
I haven't seen these photographs, but looking at them now, they look like less red on the bottom.
Yeah, absolutely. Fewer red dots and less red. So so that was the use in angiofibromas. And then we also have used in other manifestations, but not so much more in a case report sort of thing. So there was a trial for LAM, and so essentially, but not as big as the EXIST trials. And so it does show a reduction in the deterioration. They don't deteriorate as much, and an improvement in the lung function. And I know there are ongoing trials that are more sort of well, I've lost the word. Oh, randomized controlled trials to look into this even more. And then there are anecdotal case reports for a reduction in cardiac rhabdomyomas size. Now, part of why these were case reports is that we don't normally treat rhabdomyomas because they normally go away by themselves. We don't really need to treat them. And so only the kids in whom there's a really, really big one do we ever try to do it. So it's hard to have a trial when we don't normally treat them. So the standard of care is nothing, right? But the anecdotal case reports are that it does shrink. And some people have even tried it in a pregnant woman who has a fetus with a really big cardiac rhabdomyoma to treat the mum to see if it shrinks, and it does seem to work there as well. But we don't have those randomized controlled trials because we don't have those numbers for that.
Our cardiologists sometimes say it melts things away, though. Not that that's scientific.
It works very well.
It's fast, it's supposed to slow regression.
Sorry, Denise, just had trouble hearing you then. If you could, yeah.
Our cardiologist who works with us in TSC, he says that it melts away if they use the sirolimus.
It works very well, even if we don't have the official randomized controlled trial to prove it.
Yeah, and we don't need to.
So we've used it in so many different things, and we know it works so well in TS. So then the question, of course, comes, well, where to from here? What's the future of using mTOR, right, in TS? And to talk about that a little bit more, we are going to take a slight detour away from mTOR inhibitors because that will help our discussion. So going back to this picture that we looked at before, we've now added bits to it. So what we've talked about was all these green things. So we've treated, we have the condition caused a problem or a growth of some description, and then we try to treat it, right? We're trying to treat things at the end, when things have already happened, when the seizures have already happened, when the seizures already happened, everything has already happened. So of course, the next question is, well, what if we don't need to wait till it has happened, right? So we're going to concentrate more on this side of this equation here, the sort of abnormal neurology sort of connectivity side of things, because we don't really know how to prevent things from growing or happening because they might never grow as well. But what we do know is that for the seizures that we get in TS, if we did, would they get electrical seizures before they get seizures that you can see with your eyes? And so that became a very important point because there was a group, and Denise, I'm going to pass this on to the neurologist to talk about EEGs, because why would I, as a geneticist, talk about EEGs? It goes to, so that's what this next bit, this is the detour, right? So we're talking about using vigabatrin instead of mTOR inhibitor before the seizures start. So I'm going to pass this on to Denise now to have a chat about that.
Note how vigabatrin is in blue, whereas all the mTOR inhibitors are in green. So it is not an mTOR inhibitor. It does have a tiny, tiny, tiny bit of anti-mTOR function, I believe, but primarily it's GABA. So I've titled this slide, Preventing Epilepsy in Babies with TSC, because that's what we want to do. Just going back to this slide again, if we have seizures, we know that babies with seizures, especially if they have seizure onset earlier and earlier, they have an increased risk of developmental delay and autism spectrum. And so those two kind of come hand in hand. We do independently have risk of developmental delay and autism with tuberous sclerosis complex already, but because of this atypical synaptogenesis and just the way the brain was formed, But we don't want to add to that. And the seizures is really the modifiable risk factor. So how do we prevent that? You know, antenatal and early diagnosis of tuberous sclerosis is increasing. I think that's because we have better and better healthcare around pregnancies and doing more kind of late-term scans, and often we'll detect the cardiac rhabdomyomas then, raising the question of tuberous sclerosis even before the baby is born. You know, there is a window of opportunity for pre-symptomatic intervention or prevention for prevention of epilepsy in TS, meaning that, you know, if we can find them, if we know that, you know, the baby has tuberous sclerosis, but the baby hasn't yet had seizures, then is there something we can do in that period of time to either stop the seizures from happening or to delay their onset, to try to protect the brain as much as possible from starting to fire up things we see in EEG. So EEG is a good marker. You know, Joyce Wu and the group in America showed that in 2016, that it's a really good biomarker showing that, you know, the epileptiform discharges, so spikes and spike wave on the EEG has a positive predictive value of 100%, which means it will definitely predict for the storm of seizures coming. It's just when. And usually you get about a month in our experience. So for the development of epilepsy in a series of 40 children, so 40 people had EEG changes, and then they all went on to develop seizures. We know that earlier seizure onset in infantile spasm leads to worse developmental outcomes and higher rates of autistic spectrum disorder. And previous trials that you might have heard about, notably, you know, the most important ones are one's called EpiStop and one's called Prevent. EpiStop is from a European group, and the Jozwiak in Poland, and Kate Riney as well in Brisbane contributed to that group, and Prevent is the American version. But they both did quite similar things, just slightly different study design, but in essence, they used vigabatrin whenever they saw some EEG spikes happen in babies who had TSC who hadn't yet had seizures. And when they treated them, you know, the group that had vigabatrin, they had, you know, delayed seizure onset compared to those who were treated with placebo. And they had lower rates of infantile spasm, but there were no differences, statistically significant differences in the developmental outcome at 2 years of age, 2 years. So it does help. And that's why we use vigabatrin a lot, but it's not the full answer to the story. And so I guess that begs the question, well, what if we didn't use vigabatrin? What if we used mTOR instead? Or what if we used both? You know, we don't know. And so this is where we, Claire and I, conceptually think the TSC steps is. You know, we're trying to get these EEG discharges, and what if we treated them before they even had EEG discharges? What about this time when we're just watching them with EEG? What if we treated them with mTOR inhibitor? So that leads us to this new slide called TSC Steps, which is the clinical trial we're running at Sydney Children's Hospital at the moment in conjunction with Darcy Kruger and Cincinnati Children's. I think there's 9 other US sites, and we're the only non-US site. We're very lucky to be part of this. It's the FDA-funded trial, and we have our local philanthropic funding as well, so we're not part of the FDA funding. And the drug we used is sirolimus, as you can see there, oral solution, and it's randomized in a 2-to-1 fashion, just like, you know, the EXIST 1, 2, 3 trials, and it's placebo-controlled. So there's a 33% chance these babies will be on placebo and a 66% chance they'll be on drug. And it's a yellow liquid, comes from the pharmacy. We can't tell. We're blinded. We're all blinded, except one doctor in Australia. And so the outcomes, you know, the outcome measures, why are we doing this? We're trying to see whether giving sirolimus to babies who haven't yet had seizures, but we know they have tuberous sclerosis, and we know that they have an 80 to 90% risk of seizures within the first 2 years of life. Can we prevent or improve the epilepsy? Does it become less refractory, for example? Is the drug sirolimus safe and tolerable for babies? And does it help with the baby's development? So currently we're recruiting babies. Inclusion criteria, in essence, is that they have tuberous sclerosis. They must not have any seizures or even electrical seizures, but allowed to have little spikes on the EEG. and they have to be 0 to 6 months of age, and they can't be, have multiple corpora, can't be too sick. So we opened that in 2021, and we have 5 patients. One patient has completed the trial, so it goes till 12 months of age, and then from 12 months to 24 months, so from year 1 to their 2nd birthday, they get open label sirolimus, so everybody gets it. And then at 2 years of age, they stop, and they may continue the sirolimus, they may not. That's a discussion between me and the parents, but the trial stops. So we have one that's finished the trial now. We have 2 patients who are on that open label section, and we have 2 little babies who are still in the blinded phase. So they're doing very well. Well, we have yet to know what the results are.
So that's where we're at now. So I just thought we'll bring us back to our lovely journey that started in 1964, and we're in 2025 now. We've gone through, all this discovery, all this use for various things, various manifestations of TSC, and now we're at the stage where we're trying to use it in what we think is the sort of disease-specific manner, right? In a way to try and stop things from, or prevent things from happening, or reduce the chance of things from happening for babies who have TSC, in hopes, of course, that they will have a better outcome in the future. And who knows where we'll go from there. That's why I drew a random yellow arrow at the end. Like the journey doesn't stop here. It will continue, but this is where we're at in 2025. So we just had the take homes. Essentially, we know that mTORs work for multiple TS manifestations. We've got lots of data to support that. There, of course, no drug is without its side effects, but usually the side effects are pretty mild for people who are on it for TSC, and it's usually well tolerated. And of course, these new trials are sort of the up and coming thing that we're doing right now. And so with that was the end of our talk. And of course, we're happy to have a discussion and answer any questions, hopefully. And yeah, so I'm going to stop sharing my screen so, we can see everybody again. Yeah, and we'll hand it back to Jackie, I think.
Thank you so much, Claire and Denise. That's really fantastic. And you got in there in under an hour, so well done, because it's a very complex subject and a lot to cover. Thank you so much for that. Now, anyone with any questions, please either come off mute and ask them directly, or if you want to put something in the chat, if that's your preference, that's fine too. Katrina, did you want to kick off with a question? I'm sure you've got one, because, you live and breathe this stuff every day as well. So why don't you kick off with a question?
Thank you so much both for just such a wonderful talk, so informative and on such a complex subject. My question was about when someone has to go for surgery, how long would you discontinue everolimus for? Like if in that case, would you stop early and then continue like through recovery, or what would you do?
Good question. In general, for me, I take it as a case-to-case basis, because it depends a little bit on how dependent they are on the drug, right? So, for example, it depends on whether we're using it for a solid organ indication versus like epilepsy. For example, if the epilepsy is going to go really terribly, if we take it off, then you might not want to take it off super early, like 2 weeks beforehand, versus, if they're having it for a solid organ indication, and you might be happy to take it off because it's probably not critical, see what the last scan shows. In general, we like to take it off a week beforehand, and probably 2 weeks after. Depends a little bit on the wound healing. I often have a conversation with the surgeons and say, how much do you need that? Yeah.
Thank you. And I just had one more as well. Often with winter rolling around, the other question I get commonly is it okay to have the flu vax, COVID vax, etc. While with taking everolimus is probably another common one that I would get asked.
Yeah, great question. Great question. Probably a little bit better, best answered by an immunologist who understands kind of the ins and outs of the immune system a little bit better than me. Around the time of COVID, I remember having lots of questions, and Sean Kennedy and I digging into the literature and things. I haven't looked for newer literature since, so all I can talk about is my experience around that time.
Yeah.
And what we ended up doing is finding a couple of papers which found that people who had tuberous sclerosis and were on everolimus, or they were on everolimus for, organ transplant rejection, anti-rejection kind of indications, did have the vaccine and they were fine. So they were not harmed by it, and there were many for that. And the second thing is, there were people who had it and were on everolimus or sirolimus, and they might have been in a group home or something, and people didn't understand that weren't aware that it was an immunosuppressant, and then they got COVID and they recovered fine as well. So it didn't seem to affect their length of illness or admission to hospital. But I suppose if they were, obviously if we did know, then I would advise, if they had a fever or they were seriously unwell, then that they pause their everolimus or sirolimus until they got better.
Okay, thank you.
No problem. I can see a question online from Caitlin.
Okay.
Is it all right if I talk to that one, Jackie?
Absolutely, Denise, please do.
Yeah, it says, that Caitlin, you said, I was on everolimus for 6 days. I started to have some neuralgic pain in my right rib and was told to stop it. Could this be a side effect of it on the nervous system? And you're put on pregabalin for the pain. I'm so sorry you went through that experience. I don't have any experience. I have not seen that myself, and I have prescribed quite a lot of everolimus. So it's not an indication that I know of, and kind of in writing this talk, I kind of reviewed the latest literature and I couldn't see that anyway, but I didn't specifically look for that.
No.
I'll go away and look at that.
Yeah, it was very unusual to the doctor that was treating me for AMLs.
Yeah.
Yeah, I've had a pretty tough trot over the last 2 years, but
Oh.
yeah. Probably also I have another question. What does mTORs have in connection with hormones, especially in females, like around about 30, like 30 years? So in more adults. Do you know anything around like the hormones and the mTORs?
Yeah, and the mTOR, the drugs themselves.
Yeah.
Yeah, great question. Unfortunately, I don't usually see adults. So
No.
I don't have great experience in it. A lot of the patients we do, when they have a 13 or 14 and their periods start, we often try to just control their periods and make them manageable. I haven't seen too much in terms of menstrual irregularities, but what I did learn, I put on the slide already. So I can't talk too much more and be too much more helpful to you, unfortunately. But it does sound like the drugs do have a bit of an effect in changing the periods. That's certainly a thing, and it does cause menstrual irregularities, which is obviously a pain and very troublesome, and also the periods to go away, secondary amenorrhea.
Yeah. My seizures are menstrual related. Yeah.
Yeah, that's very troublesome.
Yeah. Thank you anyway.
No problem.
Thanks, Caitlin. If anyone else would like to ask anything, and another way you can draw attention, or Angela, I can see you've put your hand up. Yeah.
So my daughter is 30. She's got heaps of AMLs. She's got LAM. She's had no seizures because of we removed a large one when she was 15.
Yeah. Right.
And she's got them kidney, liver, lungs. The everolimus completely got rid of all the angiofibromas, so she's got beautiful clear skin now after having the whole face covered. And it suppressed the just about everything else. Hasn't removed them, but suppressed them. Now she's been on it for over a year now. And she, in the beginning, had some mouth sores, and we decreased the medication. And then she's had went back on no mouth sores at all.
Great.
now she's starting to get a lot of them again and in a lot of pain with them. I haven't done anything about it yet because we've got no TS clinic over here in Western Australia.
Yeah.
So nobody really knows what to do with them.
Yeah.
So do you recommend pausing it again for a while, even after she's been on it for so long now?
Yeah, there's a couple of different things I would ordinarily advise, but I'm not able to advise specifically on your situation, but I can tell you what I normally do. But most importantly, I tell you, go talk to your GP. I did find a couple of little resources on the internet that Darcy Kruger's put in, like little parent seminars as well, like similar to this one. So you might like to point your GP to that or even this talk.
Okay.
The things that we tend to do are, I mean, you can pause it, we can decrease the dose, but also I find that, I had a patient who went on a long haul flight and kind of he broke out in mouth ulcers on the way there. I suspect it's got to do with the decrease in kind of humidity.
You know what? We've just been to Malaysia and that's where she got her first one.
Yeah. So when that happened to the boy, the mum emailed me and I gave her a script for dexamethasone mouthwash. And I think the GP would be able to prescribe that.
Yeah, I just screenshotted that, so I'll ask her about that.
If you just Google dexamethasone mouthwash and oral ulcers associated with everolimus, there was a paper that talked about everolimus being used in breast cancer, and they trialed the mouthwash prophylactically to see if the women got mouth ulcers or not. So same drug, different indication, but again, trying to, everolimus, same drug, trying to see whether that might be interesting to bring to your GP and say, look, and it's usually I just do it for about a month or a week or two, swishing and spitting for about 4 times a day. I can send that to Katrina or Jackie and they can forward that to you if you'd like.
Okay, that'd be great. Thank you. Yeah, but it's been a wonder drug for us, definitely.
That's usually the best in terms of pain relief immediately, but just lots of water.
Okay, thank you.
Thanks, Angela. We have a couple more questions in the chat, Denise. So we have Joel from New Zealand who's saying, if everolimus is not helping with seizure control, is it worth staying on it to prevent other issues arising? And does it help with cognition?
That's an excellent question. I'm often in that boat. I think my first question would be about whether we've optimized it as much as possible in terms of whether we've gotten to the higher doses. As you can see, you might just get a little bit more benefit or maybe 10% more people get a bit more of a benefit, if they're on the higher doses. So I would, as long as, Joel, you're the person with TS in your life, is tolerating it, so they're not getting bad mouth ulcers and they're not, having lots of issues with the side effects of mTOR inhibitor, then I think it'd be worth pushing it up. So that's the first thing. The second thing is then, sometimes we take it off if it's troublesome, and sometimes families like to keep it on. And so I think it's one of those things. I have a long chat with the families and I just see how they're feeling and whether there's, the question is it contributing to polypharmacy, so having lots of drugs already and it's just another drug on board? Is it stopping us from using something else? Is it an opportunity cost? We don't have good data at all to show that it helps with cognition at the moment. And we certainly...
So just before we go into that, so I think that's a watch this space because there is a trial ongoing to look at that question.
Yes.
So
we feel like it might, but we can't, I can't scientifically recommend that right now.
Yeah, but the trial is happening. I can't remember what centre's doing the trial, but I found the trial. So that might be a watch this space and see what the conclusion of that trial actually is.
Yeah. And one of the difficulties with seizures, cognition, and mTOR inhibitors is that, especially in young people, is that it's often quite linked. So trying to figure out the effect of mTOR and how it helps development or how it helps people's cognition is that independent? Is it just because the seizures are better or they have less intellectual activity? Trying to tease those apart and making sure it is independently helping cognition.
Thank you, and thanks, Joelle, for raising that point. If anyone else wants to ask anything, you can, if you don't want to come onto the camera, you can click on the react and raise your hand so that we know that you want to say something. If you just want to then come off mute and ask something. I'll just go to something in the chat from Janet, who says, my daughter's also had extraordinary results with everolimus, but now has had some issues with abnormal pap smears. Not sure if this is related. And you probably aren't either, but I just thought I'd throw it out there if there's anything you want to comment.
I'm not sure that's related either, but I'm so sorry that's happened. I hope it all works out okay and she stays healthy.
Thanks, Denise. Karen, I can see you've got your hand up. Would you like to?
Sorry, Clara wanted to just say a comment.
Oh, I think just the more important thing is, like, because we always, I think with anything, we like to go, oh, like, oh, they're on this drug or they'll have this condition, does this relate to that? But I think the important thing is to make sure that we've ruled out all the other reasons why something like an abnormal pap smear can happen. So I think from a safety point of view, that's what we would recommend just with anything. Like, because as a geneticist, you know, half the patients that come to me ask, well, they have this condition, they now have this new thing, is this related? And it's not an excuse or anything to not look into it like we would with anybody else who wasn't on everolimus and everything. So I think that's the more important thing. And it might be related, but we need to make sure it's not anything else first, would be my advice from that point of view.
Really good point. Now, Karen did have her hand up. Karen, did you still want to ask a question?
Yeah, I did. I was just wondering if putting medication, if putting children on medication earlier would increase the risk of possibly decreasing tolerance towards like this kind of drug or any like epilepsy drugs in the future. Like if you put children on a drug like sirolimus as so young, would they have a tolerance towards everolimus
later
in the future? Yeah, exactly.
That's an excellent question. I suppose if that were the case and that were a consideration, that you might want to not use it initially to make sure that if they have a brain tumor, that we could definitely shrink it. Yeah, it's a great thought. I don't think any studies have shown that. Shown any tolerance to the drug. We certainly do see tolerance sometimes in drug, particularly with a group called benzodiazepine, so clobazam, clonazepam, that sort of anti-seizure drug. But not so with everolimus. I'm not aware of any data showing that. And certainly it's not, I don't think it's because we don't have the data either, in that if people on everolimus, and if it works, like it shrinks the brain tumor, it makes it smaller, as we've seen some of the MRIs, people tend to stay on that long term for years and years, because once they take it off, then it's not curative, it's just suppressing it. Once they take it off, then it'll grow back. And so I suspect I don't have the data for it, but I suspect there are people who have been on it for years and years and years. And certainly for me, even though I only follow my patients to 18, and so some of them, you know, I know for 18 years, some of them I know for 10 years, you know, if they're on it, they tend to stay on the same dose. I don't tend to have to increase the dose because it stops working. They don't get to ridiculous doses or anything like that.
I think it's just funny that you say that, because I think I should know that, because I was put on it I think when I was 20. I'm now 31.
Yeah.
So I've been on it for quite a few years myself.
And have you had to increase the dose or anything like that?
I've had a few fluctuations. For a while there, I was on it for about I was on 5 milligrams morning and night.
Yeah.
And that was a pretty frequent regular dose I was taking. And then as of November last year, my blood pressure had skyrocketed. And my GP and my specialists for kidneys and stuff like that recommended I lower the dosage to 4 milligrams a day, just until we get the hypertension kind of sorted. But I was like, because I've got some friends who have epilepsy, and one in particular, she is drug, what is it called? Like she's taken a lot, resistant. She's resistant to a lot of drugs. And I'm wondering if like the earlier you were to put children onto it, would the chances of that tolerance increase, I guess. But I guess, you know, with my own experience, you know, I think I was thinking that just because I experienced this doesn't mean other experiences would be the same kind of thing.
You're right. Thank you for sharing your experience. It's so valuable to hear from you, and I really appreciate it. I'm sure other people online also have learned a lot from that. I think that epilepsy in itself is a little bit different. We find that with epilepsy treatment in general, so not just with mTOR, but also with anti-seizure drugs, if we can get it controlled early on, or if it's recognized early and treated early, that gives us the best chance of keeping it down. It's a bit like a runaway train or a bushfire. Once it's been out of control for a long time, that in itself can kind of self-perpetuate and can make it a little bit trickier to bring it down.
I'll just say that when I was a very young child, I had quite a lot of seizures, like hundreds a week, and I was put on like Abatrin and Dilantin, and then Keppra at 10, and my seizures stopped completely, and I haven't had a seizure since then. But over time, as like a teenager, I had experienced some kind of sensation in my body that might be related to my epilepsy. And I will say that when I got put on everolimus, that stopped. And I've realized that with the decrease of the everolimus now, I've begun to have that again after not having it for a while. So all this information is quite interesting.
I wonder if, you know, you describe that to your doctor, maybe they, you know, the question is whether that would be like a small seizure type, something we call an aura or a focal impaired awareness seizure. But I think it would be good if, you know, the next time you talk to your neurologist or your, you know, a doctor, maybe just to mention that feeling in your body. But I'm glad this is working for you. That's wonderful.
Thank you.
Thanks for sharing, Karen. And Letitia has been very patient. So Letitia, would you like to ask a question?
Yeah, thank you. I just want to say a big thank you for the information session. It's been great. We've got 2 daughters, both with TSC. My husband and I both don't have the gene, so it was a big surprise to us. Our youngest has had frequent eye styes, and at the moment she's got one and it's turned into an infection. So is that something that's ever been common as a side effect? Styes?
Yeah, good question. Not that I'm aware of. I'd have to ask my ophthalmology colleagues when I get back to work tomorrow, you know, how it starts and kind of, I'm not too familiar with how that works. So just thinking about things. But I think the fact that he got infected, that might have something to do with it.
So
like in the general infections are a little bit higher.
Yeah, we've been advised, we went to the ED because our GP couldn't see us, but he's advised her to go off for a week off. Is that something that I should do as soon as she gets a sty so it doesn't go to the infection start? Or
I probably would decrease it if you had an infection, but not if you have a sty, I think, unless there's signs of infection.
Yep, no worries. Thank you so much. It's been great to hear all the information.
No worries.
Very
Thanks
grateful
for your input.
Thanks, Letitia. Do we have any other questions for our wonderful expert doctors here? I'm not seeing anything. So thank you again, Clara and Denise, for a really informative presentation. And thank you for sharing both your time and expertise with us, and for everything you guys do to support the TSC community here in Australia, and your whole team there at Sydney Children's. I know there's some of your colleagues who've also dialed in tonight. You do such marvellous work, and also the research you're doing to push things forward and make sure that we keep advancing on that journey, so Clara can keep coming up with new diagrams that put the arrow going, you know, up and forwards, and really appreciate everything you do. But most importantly, thank you tonight, and thank you everyone who's attended this evening. It's been lovely to see you all. Please don't forget TSC Global Awareness Day next week and our Light the Way campaign. We'd really like to have you on board, and if you've got any questions on that, please do get in touch. But it's great to see you, and thank you again, everyone, but particularly Clara and Denise. Thank you so much, and good evening.
Thank
Jackie.
you.
Thanks, Jackie. Thanks for having us. The pleasure was all ours, and the TS heroes and the families. Thank you very much.
Thank you.
Yeah, girls.